Tibial shaft fractures. These are mostly high-incidence open fractures. By model distribution, young and less than 30, older more than 50. Younger have high-energy transverse and comminuted fractures. Older have low-energy spiral fractures. These are vehicular injuries, mostly pedestrian struck by vehicle or motorcycle or crash injuries. Regarding the history examination, history examination is important. Radiograph is important. Possible CT scan or a vascular study may be needed. Regarding the mechanism of injury, low versus high, isolated or polytrauma, patient demographics and past medical history like age, diabetes mellitus, smoking, substance abuse, obesity, and immune compromise. Again, the evaluation of these patients, physical examination is important to exclude open or close pain, compartmental syndrome, soft tissue injury, vascular injury, and neurological examination like motor and sensory. Trauma bay x-rays are quick tools. Ankle and knee x-rays should be done. Periarticular extension should be assessed, especially distal tibia fractures. Syndesmotic ankle or proximal tibiofibular joint injuries are sometimes missed. Proximal 1/3 extension to tibial plateau is less common but more devastating. Articular fracture must be part of the surgical plan. Vascular evaluation is indicated if distal perfusion remains abnormal asymmetrical despite fracture realignment. Handheld Doppler, ankle brachial index, CTA, vascular consult, and angiogram. Compartment syndrome, as this is high energy trauma. Clinical diagnosis is an awake patient. The findings are pain out of proportion, pallor, paresthesia, pulselessness, and paralysis, which is late findings. Intubated aptented diagnosis confirmed by compartment pressure and regarding open injuries, Castillo classification is important. Type 1 is a clean wound less than 1 centimeter. It's a low energy fracture. Type 2, the wound size is 1 to 10 centimeter in length without extensive soft tissue damage, without high energy fracture types. Type 3A are wound associated with more extensive soft tissue damage than type 2. Any wound which is more than 10 centimeter, high energy fracture, that is segmental fractures. 3A must have skin defect that can be treated with closure or skin grafting. 3B is wound which require muscle or skin flap for coverage. 3C is a vascular repair requiring for revascularized leg. Isolated less vascular injury with well-perfused foot does not classify as 3C, even if the vessel is repaired. A Charney classification grades soft tissue injury in closed fractures. 0 is little or no soft tissue injury. Type 1 is superficial abrasion, mild to moderate. Type 2 is deep contamination with local skin and muscle contusion. And 3 is extensive contusion, crushing of the skin and destruction of the muscle, a severe fracture. Treatment is non-operative IM nail plate fixation, external fixation, and special techniques. For a non-operative management, the varus alignment should be less than 5 degrees, valgus should be less than 5 degrees, apex anterior angulation 5-10 degrees, 0 to 10 degrees of rotation, and shortening of 10 to 12 millimeter. Adequate alignment and length in a splint or cast. Soft tissue can tolerate cast. Significant anesthesia risk. Patient refuses operative treatment. Traditionally, these alignments are somewhat arbitrary and unreliable. These malangulations rarely exist in isolation. Shortening of this amount often no longer accepted. The close reduction should be done. A well-molded long leg cast should be applied. It should be conscious sedation often requiring for best reduction. Be cautious regarding the risk of compartmental syndrome. Close follow-up to maintain the alignment. Wedging of the cast is sometimes needed. Conversion to open treatment if unsuccessful. Transition to patellar bearing cast at 2 to 4 weeks time. Sarmiento et al. Had 1,000 tibial fractures and showed a non-union rate of 1.1% with 94% of the patient healing. Sarmiento results have been referenced for years but has not been yet replicated. Most recent RCTs shows low rate of non-union malunion complication and return to work. Intramedullary surgical treatment indication is severe initial displacement, failure to obtain adequate close reduction, open fracture, vascular injury, soft tissue envelope that precludes class application, patient unable to comply with close reduction treatment, patient require early return to activity. 96% prefer IMN for close fracture or open type 1 open fractures. Intermediate minimize soft tissue stripping, allow immediate weight bearing compared to RIF, but can be associated with knee pain. Two approaches for intraperoneal, infrapatellar approach and suprapatellar approach. The infrapatellar approach is a traditional approach. Knee is hyperflexed to excess starting point. Knee hyperflexion can increase deformation forces in the proximal tibia fractures. X-rays can be sometimes difficult. Suprapatellar approach is a semi-extensile extended position. Starting point assessed through the knee, reduces deforming forces, especially the proximal 1/3, but needs special instrumentation to protect the knee soft tissue. It is shown that suprapatellar nailing approach decreases risk of malunion and decreases risk of postoperative knee pains. Starting point is virtually important for alignment. Ideally, guide wire placement for average tibia just medial to the lateral tibial spine on true AP knee X-ray, and just anterior to the articular surface and parallel to the anterior tibial cortex on lateral X-ray. Assuring AP and lateral views with appropriate rotation is crucial. True condyle X-ray has overlapping condyles. After guide wire optimally positioned, it is over-reamed by entry reamer. A ball tip guide wire is placed into this pathway. A ball tip wire is advanced across the fracture to the physeal scar in the distal tibia. Endpoint of the nail also key in optimal alignment. Endpoint should be at the center of the talus. This is very lateral within the distal tibial metaphysis. The wire should be centered on the lateral view as well. Reduction must be performed prior to reaming and the fixing of the nail. Reduction technique: number 1, manual traction and reduction. Number 2, push pass technique. Number 3, external fixator assistance. Number 4, clamps. Number 5, shank spin. Number 6, plate assisted nailing. Traction, bumps, and manual reduction. A push pass technique. Reaming is performed up to and past the fracture site, but not at the fracture. The reamer is pushed through the fracture. This preserves cottage edges at the fracture site that help optimize reduction when nail is passed. Push past technique. Reaming is performed up to and past the fracture site, but not at the fracture site itself. The reamer is pushed through the fracture. preserves cortical edges of the fracture site that help optimize reduction when nail is passed. External fixator can hold nail and reduction for reaming and nailing. Wires or pins must be outside the nail path. Especially helpful metaphyseal fractures or with limited assistance. Clamps placed percutaneously in closed fractures, placed through the wound in the open fractures. A unicartical plate can be employed also. Sometimes helps for segmental fractures. Soft tissue stripping and loss of peripheral blood supply is at the fracture site, so not used routinely. Another technique will be fibula fixation ORI versus intramedullary nail. Helps establishing length. Some studies indicate intact or fixed fibula may cause higher rate of tibial delay and non-union. Reaming creates an intermedullary path and allow for a large diameter nail. Reaming is performed over a guide wire. It is critical to maintain fracture reduction during reaming. Once chatter is noted, sequential ream to 1 to 1.5 mm over the desired nail diameter. There is a reaming debate. Reaming nailing can be destructive for endosteal blood supply, but the blood supply rebounds within 2 weeks. Unreamed nail preserves the endosteal blood supply, but must use a smaller nail. Until now, key points is that both reamed and unreamed are acceptable. Avoid small unreamed nails, ideally not smaller than 9 mm. Most common nail diameter uses 10 mm. And do not ream with tourniquet elevated. In proximal fractures, tend to deform in valgus and apex anterior angulation. Distal fractures tend to go on to valgus. A blocking or polar screw can prevent the correct angular deformity. Blocking screws are placed on the concave side of the deformity. Regarding open reduction, not very well preferred in tibia fractures, but is an option. Proximal and distal metaphyseal fractures, articular extraction fractures, or previously implant like total knee arthroplasty, or deformity that precludes IMN. Minimally invasive percutaneous osteosynthesis, modern anatomical implants, fluoroscopy assisted, less than 9% deep infection and wound adhesions. Regarding the plate versus nail, existing literature indicate lesser angular malalignment with ORIF when compared to infrapatellar nailing, especially in metaphyseal fractures. Newer studies have shown alignment in metaphyseal fracture nailing with suprapatellar technique plus external fixator assistance or blocking screws. In open fractures, external fixation can be coupled with soft tissue treatment like negative wound pressure therapy, NPWT, negative pressure wound therapy. This can lower the need for flea flaps in open tibia fractures. NPWT does not lower the infection rate itself in Gustilo 3B. Antibiotic bead spacers can be used. Return to OR for serial debridements. In bone loss, muscular technique can be utilized. Ring fixators can be utilized. Numerous scoring system is available if there is a polytrauma case which poses amputation. Amputation is performed when limb salvage, number 1, poses significant risk to patient survival, number 2, irreparable vascular injury, number 3, warm ischemia time more than 6 hours. Functional results will be better with prosthesis, relative indication, And number 6, patient prefers amputation to course of treatment for salvage relative indication. Numerous sclerotic systems should be remembered. Significant bone loss is more than 10% of open fractures. Can occur anytime. Can cause various treatment options for bone loss are acute shortening, bone grafting, allograft or autograft, induced membrane bone grafting like Mascolo technique, bone transport like distractive osteogenesis, vascular fibular graft or osteocutaneous flaps. So in case of bone loss, you can do number 1, acute shortening, number 2, bone grafting with number 3, induced membrane bone grafting, number 3, bone transport, number 4, vascular fibular graft, number 5, osteocutaneous flaps. The treatment strategy may affect debridement. Bone grafting methods such as Mascolo technique, bone spikes are left to maintain bone volume preserved. Bone transport is distractive osteogenesis. Potentially devitalized bone spikes should be removed. Optimize bone contact and mechanics at docking. Trade-off is greater bone loss versus more thorough debridement. The Mascolo technique PMA spacer is produced to prepare grafting site. Create pro-osteogenic membrane. Provide space for bone graft. So these are the following are the benefits. Number 1, it prepares the bone graft site. Number 2, it creates a pro-osteogenic membrane. Number 3, it provides space for bone graft placement. Simple technique treatment require least follow-up and compliance. High risk of infection and failure in tibia than other locations due to poor soft tissue envelope. The bone transport techniques, external fixation technique, integrated technique, and all internal technique. Regarding the bone transport technique can be achieved by external fixator like Elizarov, bifocal frame, monolateral frame, or cable transport. Integrated can be cable transport and then nailing or transport over the nail. And all intern will be bone transport nail.